Hello and welcome to another episode of Awareness Programs in Healthcare. I'm Rajiv Mathur, Executive Chairman of Critical Care Unified. Today we have with us Dr. Himaaldev, a young dynamic critical care doctor who is heading up the ICU of Apollo Hospital at Sheshadripuram in Bangalore. He did his MD from the prestigious KMC College in Bangalore with a gold medal and is an F&B in critical care. Apart from that, his list of qualifications run fairly wide and deep, where he's done his European diploma in critical care from Dublin, is also work experience in Royal Adelaide Hospital in Australia. Today, Dr. Himaaldev will help us understand and debunk a lot of mysteries that surround around what happens in an ICU of a hospital. A lot of us are involved where we take our relatives, family members, and then they're admitted in the ICU. And with a lot of anxiety, we are all sitting outside and waiting on whatever reports that we can get from the ICU. And I have here Dr. Himaaldev to help understand what happens in an ICU, what are the interventions that take place, and what we as family members and next of kin should be aware of. So, welcome Dr. Himaaldev.
Thank you.
Thank you for giving us the time today.
Thank you. Thank you so much.
I was wanting to ask you from a very layman perspective, what happens when a patient is admitted into an ICU, whether on recommendation of a primary physician or maybe some episode that is of an acute nature. So if you can walk us through as to how do you implement the processes when a patient comes for admission in the ICU?
Right. Thanks, Mr. Mathur, for having me here, and a very varied session, and to make understand what happens inside the critical care unit. So as the name specifies, critical care unit is also called as an intensive care unit. So whatever happens inside, it is actually in a very intensive way, very specialized way. So you would have seen patient coming into the ICU and we close the doors, and it's only the specialized or a professionals who handle these kind of patients. So it is a unit, a specialized unit, where we admit a very sick patient who requires a very highly specialized intensive care. So we have a high-end monitoring machines, high-end organ supportive measures, which cannot be managed in the ward or somewhere else outside. Okay, so the patient is really sick when he comes into the intensive care unit, and so he will be taken care by a qualified medical professional, a team of professionals, and also team of the paramedicals, like allied specialties like nursing, the physiotherapy, and also the other specialties. And interdisciplinary approach we call, not only one specialist, the other specialist also comes into picture, and all together they try to save the patient.
So is it invariably that patients actually first go to the emergency section of a hospital and then are recommended for admission in the ICU, or are there other routes that are also open to get into an ICU?
Okay, so there are two ways to get into the intensive care unit. So somebody who comes in very critical, he goes to the emergency first, and there he gets the initial resuscitation, then he'll be shifted to the intensive care unit. What happens in the ICU is, we have these high-end machines which can be, which are like ventilators, which are BP, blood pressure supportive the machines, and also sometimes some patients require a renal replacement therapy called dialysis, which cannot happen in emergency. So we need to take them to an ICU and stabilize them further. So we need to maintain what the emergency have done it and take it further. So we can monitor the progress, and also if there is any deterioration, we can handle them. So that is one way to get into the ICU. The other way is somebody who is in the ward in the hospital, suddenly he has an emergency situation. Suppose he has a heart attack, he has a stroke in-house, or suddenly he has any other problems which is acute, he will be immediately shifted to the intensive care unit, and then from then onwards we take the course of action as such.
So is there any kind of a situation that you could possibly elaborate on, take a case of a certain type and how would the whole team, what is the first point of contact within an ICU, and how do you then trigger off a multidisciplinary team? How do the specialists come into the picture? If you can just help us walk through with a case that you may be, which is very common in an ICU, that would really be helpful.
Yeah. So let me be very clear. When I say intensive care unit or critical care, in our Indian setup, there is always a paranoia that somebody goes into an ICU, it's the end game. They don't come back. Somebody goes on ventilator, mechanical ventilation, no, they will not come back. That's all a myth. The things have evolved now, and if you see a very high qualified or a very good tertiary care unit, the outcome is very good. And if 10 people go into the ICU, there are chances that around 6 to 7 people, they do come back and they walk home. And not everybody goes on ventilator, doesn't come out. There's a very good recovery rate on ventilator also. So that panic has to go first. Okay. The subset of patients who come into the ICUs, that's what we think. What happens inside the ICU? Usually some patient who has a stroke, massive stroke, who requires the support of ventilator, he comes into the ICU. Patient has had a massive heart attack, also called as myocardial infarction. He comes into ICU. A person who has had a massive trauma, a road traffic accident, who has blood everywhere, he requires an intensive care, he requires an ICU care. Somebody who has gone into other organ failures like renal failure or a liver failure, who requires organ support, they come into intensive care unit. Sometimes some patients do come to the ICU post-surgery. That is called as a surgical intensive care unit, where we manage them post-surgically. And coming to the other question, what was it?
If you can take a case study of a certain type of a patient,
Okay. So nowadays, if you look at the recent trend, the pneumonia is the hot topic, and if you look at the COVID pandemic, there's a lot of panic created at that time of period. So the patients who had breathing difficulty, again, whatever the COVID, it caused pneumonia. And pneumonia in a different kind of subtypes. It caused mild variety, a moderate variety, and a severe variety. Mild to moderate could have been managed at home or could be managed at ward. But when it became severe, it caused a pneumonia, and also we call it as ARDS. That means a severe pneumonia. The lungs, which are like a sponge, it becomes hard, it becomes like a stone, where the oxygen supply and the carbon dioxide exchange doesn't happen. Those patients require a high amount of oxygen. We try to give it through the oxygen with a high concentration. Sometimes they do not tolerate it and they require a mechanical ventilator. So this is an artificial breathing machine which helps the lungs to ventilate and deliver the oxygen to the other parts of the body. Sometimes, even on ventilators, some patients they will not be able to exchange the oxygen. In that situation, we go into some high-end techniques which are available in only very specified centers, like what we call as an extracorporeal support, that is artificial heart and lung support, also called as an ECMO support. So what I'm trying to say is all these things cannot be done in the ward or in the lower setup. It has to be in a specialized intensive care unit. So these patients, when they come in, when we are able to put them on these ventilators or organ support, we wait for the lungs to heal. When the pneumonia slowly starts healing, we'll usually get them out of this ECMO machine and eventually out of the ventilator. But whenever we do this, they go into some other organ failures. They can go into kidney injury, may require a dialysis support, so we initiate the dialysis at the same time. Some of them may require go into something called as a shock. So they require blood pressure support, we give them a blood pressure support. We might have to treat them with antibiotics, and along with it there is something called as rehabilitation therapy. So where we always use a physiotherapist team and a respiratory therapist team, and we have to mobilize the patient, make them move their hands and legs around, and also we have to bring in the family, because the family is very important part of the treatment, because these patients will be in the ICU for a longer duration and they need definitely a family support. So we make the family intermittently come to them, be with them, give them positive reassurance along with the physical rehabilitation, along with organ support. As a multidisciplinary approach, we take them out of the ICU. And this is how a case of a pneumonia goes into multiple stages of organ failure, fights it and comes back to his life.
Actually, you've raised a very interesting point. because in the COVID first wave during 2020, I personally would commend the Indian authorities and the government and all included, where they said that for mild and moderate patients, you could do therapy or treatment at home.
Yes.
Whereas in some of the Western societies, in the Western countries, whatever the situation was, they would be going into a hospital and occupying a bed, right? Maybe a bed in the ward, but then all the same, it's a bed being occupied. So we did that very well. But tell me something, this whole thing that happened around the shortage of ICU beds and non-availability, because of course our country is so large and therefore the breadth of infections that we had in our country was very wide. So yes, we weren't prepared for it, the world wasn't prepared for it, all of that. But what were those cases that made you decide as medical practitioners that this is a case where they definitely need an ICU bed? Was it ARDS type of cases or severe respiratory, or did you see the lungs, packing up? What were those critical decision points so that people understand as to why it was important for people to be in an ICU rather than just hospital treatment or maybe even home treatment?
Right. So I think a very valid point we asked right now. Not everybody can be managed at home. We tried. We had a lot of dearth of ICU beds at that time, but unfortunately, I think there were a lot of infections during the second wave, and we were not able to actually admit them in the ICU, and many of them you would have heard lost their lives. We were not able to get into that. So there are very subset of patients. If you look at the data, around 80% of the population, they didn't require an ICU because they had very mild infections. The lungs were not actually infected very badly. Another 20% of the patients, they had moderate to very severe infections where the lungs are very badly infected. Their oxygen demand was so much that you can't deliver it with a normal oxygen. They require an artificial ventilator support. And some patients, subset of patients who are elderly, who are diabetic, who are asthmatic, who are immunocompromised, and they're on multiple drugs which can cause immunocompromised state, they require an ICU setup because they'll have other organs also to be supported. So they are the subset of patients who definitely required an ICU. And I think the thing is, ICU, as I told you, it's a closed space, and the reason why it's a closed space is to minimize the intervention from other, like for example, if you're caring for a patient, you need to be very determined, like you have to look up to the patient. So if there is an external disturbance, like for example, the family is emotional, they come and say, don't put him on a ventilator, don't put him on this, don't do this, it's very painful, don't prick him. It will actually cloud your consciousness, your judgment will be wrong. So that's the reason we don't allow the family. They become emotionally. Emotions doesn't play a role in treatment.
Yes.
As a doctor, you have to be very particular about your treatment. So that's the reason we try to be as secluded, and also to avoid infections, cross infections. We try to keep the ICU as a closed unit. And another thing is, we do allow the patients once the patient is getting better, and once he is able to recognize them and actually feel they are there, and it will help his presence. But unless when the patient is very sick, we will not let him inside the ICU, let the family inside the ICU. Okay. And the one important factor which we usually which we face as a challenge is the patients whom I explained, the pneumonia patient who's been there, not a short stay, they're a very long stay. So they would have actually drained out their resources by the time they reach the end. They have the India is not so affordable country, and usually the insurance or the cost factors usually drained out. It's all high-end therapy. The therapy comes at a cost.
Right.
And once the patient is recovering, by the end of things, you still have to have some time, but the problem of finances come into picture. So you have to have a tide over or a bridge. You can't keep them in the ward. They need at least a semi-ICU care. So that's when I think the boon of home ICU care helped us. Somebody who is actually good to go to a step-down unit, but not to the ward.
Yes.
But they want to go home and be with the family. So two aspects. One is the financial constraints. Other one, the most important thing is being with the family. So I've seen out of 10 patients, 9 patients, they get better when they are with the family. So I think the tide over from the ICU towards the home ICU care has helped a lot of patients, and especially a very good qualified critical care home care specialty, a critical care trained nurse, and immediate escalation process with a protocolized approach has helped us a long way. And we have seen a lot of patients, because you put in a lot of effort to get this patient out from an acute situation. In the end, we want the same care to be continued somewhere outside also.
Absolutely.
So this has been a very helpful thing for us, and I think we have to make use of this facility in a very right way.
One of the things, Dr. Himaaldev, is that how do you raise the confidence of the relatives and the family that appropriate interventions inside the ICU of a hospital are being implemented, and whatever the condition is of the patient is obviously being monitored very closely, because it is, the patient is in the ICU, but that whatever interventions are required are being implemented at the right time. Because sometimes the family feels, oh, if that was done earlier, maybe it could have had a different outcome. Oh, we did, maybe they overlooked something. And so there are these things which are not true, because inside ICU of a professional setup, you have a lot of processes. So I'd really, it'll be great if you can just explain some of the protocols, the processes that you have within an ICU, where the monitoring and therefore the related intervention is triggered quite quickly, so that the family feels more confident.
Right. So what happens in the ICU?
Yeah.
The patient is in ICU, he suddenly deteriorates. The first person to attend is not the doctor, it's usually the nurse, who is always in the bedside. So what happens in ICU is usually the 1:1 ratio. If a patient is on a ventilator, he is on a very high support, the nurse is always next to him. So she'll monitor every beat, every blood pressure thing, and every vitals, and she'll be able to recognize immediately. I think the same care will be given in a case of a very good home critical care unit. And when the acute situation happens, if there is a sudden deterioration of a patient, I think the nurse is qualified enough to handle this situation. I think we should let the nurses do that. What happens is, if the family intervenes too much, not only a nurse, a doctor, anybody in that situation will be confused to carry out his duties. The only way to go about is maybe let the nurse handle, because she's a professional, she'll handle the things rightly. If there is something beyond her expertise, she will definitely escalate it according to the protocol. There is always a protocol followed. Even if a doctor comes, he'll follow the same protocol, and the nurse will do that. And if there is an extra thing to be done, she'll escalate it to the doctors, and that's how we have to take it. So too much of noise or too much of interference is not going to help the patient. So it has to be in a protocolized approach. And in the hospital, we have the protocols. Suppose the patient has a drop in the heart rate, we have a protocol to start this medicine and start this thing. The same protocol will be given to the nurses who is at the bedside. Suppose there is, some patients will have a tracheostomy. The tracheostomy, if there is a block, immediately there is a steps. So you need to clear out the tracheostomy, do a suction, take it out, and if there is any block, then immediately escalate it to somebody else. So it has to be that way only.
And you have, obviously, in an ICU, you have access to the various specialists, whether they are in the form of a cardiac specialist,
yes,
or a nephrologist or whatever, because you will have a lot of comorbid type of patients also coming into the ICU.
Right.
So you have that immediate access within an ICU,
yeah,
to these specialists available either within the hospital, I guess,
right,
or within the network of your hospitals.
yes,
Yeah?
yes. So, but whenever an acute situation happens, maybe there be a multi-specialty approach. The first person who handles will be a emergency physician or a critical care physician. At least the immediate process will be tiding over the crisis.
Okay.
So the specialists come into picture later on. Unless it is a very acute situation, like there is an acute heart attack, he has to be resuscitated, taken to the cath lab and do an angiography. Rest of the things, initially you have to do whatever has to be done. I think when the same thing applies when somebody is at home also. The initial thing is resuscitation, then the specialized approach. Probably the initial resuscitation will happen at home, by enough time so that the patient goes back to the hospital and continues the treatment. That is the primary aim.
So in terms of just lowering the anxiety of the family when the patient is in the hospital ICU and they don't have access, You know, obviously, if you do a ICU type of setup at home, actually the family has all the access and they are aware of what is going on. And I'll come to that point a little bit later. But but do we have adequate communication in terms of updates? Because I've seen people who have called me and say, hey, can you please find out from somebody as to what's going inside? You know, we don't hear about the patient, we don't know what's happening. Can you please find out what the condition is? This is the bed number and all of that, right? So is there enough that we do as the medical fraternity, especially in hospitals, to communicate to the family about the situation? And of course, you can't tell them everything because then you've got all types of other issues that come up. But in your opinion, is there any scope for making it better to lower the anxiety?
As I said, the family is the most important part in the recovery. They play a very important part in the recovery of the patient, because I've seen patients when they're awake, they're going to ask, where is my mother? Where's my father? The moment they see them, their willpower increases. You know, they feel better. So what we have done in our hospital, at least, we fix a definitive time intervals. Morning a visiting time and an evening visiting time. We make them sit next to the patients, spend time with them, making sure that all the infection control precautions are followed, so that they don't give infections. There is a good barrier precautions, and give a lot of reassurance and motivation. Suppose if he is able to write it, if the patient is on ventilator, he will not be able to communicate them. So we give them the way modality so that they can write and communicate to them. Okay. In certain situations where the family cannot enter the ICU at all, because there are certain conditions where you cannot go and expose yourself to that infection. So in that situation, what we have done is a video approach. So we have a built-in video communication.
All right.
So the family will communicate to them over the phone, so that the patient knows the family is around, he's safe, and the constant reassurance keeps on happening. So that's how the communication. But it is a mandatory thing. It is a must that we have to do it. So the thing is, updates also will be given at the same time, and over the day, whatever treatment has been given also will be done at the same time.
So there is this other thing that goes around where people say that obviously everybody knows that if in a very contained environment there are patients of all types, then the chances of being able to catch an infection is much higher, right? But is there merit in what is generally referred to as ICU syndrome for a patient, where apart from the ailments and the primary or secondary ailments that the patient came with, have you seen deterioration in the condition of patient by just them being for long stays in the ICU?
That's a wonderful question. You know, definitely patients comes to the ICU because they are sicker. They'll have sometimes they do not have any infections, because ICU is a place where you have the mix of all the patients. You know, so there are chances that they can get a cross infection from other patients. Suppose there are a lot of devices, like for example ventilator in the tube or some lines. They can always get an infection, because sometimes there can be infection in the skin, or there can be an infection around. We try to maintain as much as possible the barrier precautions, aseptic precautions, everything. But whatever said and done, in the high class ICUs, the best of the ICUs also, you cannot prevent certain infections. They are called as hospital acquired infections.
Yes.
But there is a way to treat them. You have to identify them early, and you might have to change the devices and lines and optimize the antibiotics, and also follow the barrier precautions very carefully. We have designed certain ICUs. There are some negative pressure and positive pressure isolation rooms. So if the patients seem to be a very infective case, then we try to put them on a isolation rooms, so that they don't give it to others. The moment we know this patient is infective, we try to get them out, and we try to seclude the non-infective patients together and the infective patients separately.
Okay.
So we try to minimize as much as possible, and there are chances that they can get a cross infection, but they're always treatable, and we can handle it. Right.
Right. And in terms of what they refer to as ventilator-acquired infection, or is it due to prolonged use of ventilator? Because I guess a device like a ventilator cannot be just used endlessly, right? There must be with a purpose for it, and you have certain parameters that you want to focus on, achieve those, and then, you know, remove the ventilator. What is your thought on that in terms of the use of ventilators within an ICU setting of a hospital?
So you cannot avoid a ventilator. Ventilator is a life-saving device. So when it is needed, it is definitely needed. So what is our protocol says is, when the patient is on ventilator, we actually do a lot of weaning trials and try to get him out of ventilator as soon as he's better. And there are protocols where we avoid these ventilator-associated infections. Maybe the suctioning techniques has to be sterile, closed suction techniques, keep them little head end elevated, and do a constant the protocol wise, and we try to avoid it. But generally, ventilator-associated pneumonias will happen, and optimize early detection of these things and optimizing the antibiotics is the way to go. Sometimes we tend to do, we cannot keep the patient on ventilator with this tracheostomy tube for a longer time. So generally what we do is we do something called as a tracheostomy, and we try to get him out of the ventilator, the endotracheal tube, and so that the what you call the caring will become easier. They can take out the secretions better. They can liberate him from the ventilator. We call it as liberation of ventilator.
Right.
Okay. So that liberating from the ventilator will become much easier. And actually this is much safer. So in case if he becomes breathless over the time, it's easy to put him and take him out, and also the clearance of secretion become easier, and also transition from him from the ICU to a lower setup like a step down unit or to a home care becomes easier. And even in the home care setup, the most important thing is the hygiene, so you have to have a good environment, a non-infective environment, and even the nurse who takes care of the first patient, even at home in the home intensive care kind of setup, has to be very clean. So that is very important. So the idea is to not give him infection, a fresh infection. Whatever infection is there, it has to be treated, but maintain as safe practices as possible. That is the prime importance. Two most important things I would believe in anything is, one is adequate aseptic precautions with a very hygienic environment. The second one is a very good qualified nurse, that is, who can detect the miss happening early and treat it accordingly.
Absolutely. So what would your advice be to the family who is then migrating a patient from the ICU of a hospital setting into the home? Right. Because suddenly the environment changes, right? There is on the one side tremendous advantage of having family around and all of that, but at the same time there has to be some amount of isolation and whatever else that needs to be done in terms of care of a critical patient. So what would be your advice, and as a very experienced intensivist, critical care doctor, having seen a large number of patients, and when the patient does go home, how do you visualize the setting should be?
Okay, so a patient who is ready to go home, in the sense, there are two ways. A patient who is recovered completely and is being discharged, and he doesn't require any high support. That is one variant. The other variant is somebody who requires a care further, but maybe because of multitude of reasons. Maybe he requires another 1 month of the stay in the hospital, which may not be possible because of the financial constraints or because of the family's thing. And we know that the same care can be given at home, whatever can be given in a step down unit or in the ward. That is one patient where what we try to do is we train the family when they are in the ICU how to take care of if they are on tracheostomy, for example, how to identify the problems and how to take tracheostomy, how to take care of the feeding protocols, how to avoid the bed sores, how to avoid the what you call clotting abnormalities which can happen because of prolonged immobilization, how to mobilize them so that we don't break their bones or do them damage, all those things. So what they'll do is they'll come, they'll observe how we do it, they'll observe the nurses how they do it, they'll observe the physiotherapist how they do it, and we train one single person. So it's always better a single person handles same person handles their the closed one at home also. So there is no confusion. And you know that one single person cannot be there always.
Yes.
So he might have to train his family so that they can take turns, and maybe one in a day and one in a day. And they can actually coordinate with the nurse who is at home and do the treatment process better, So that doesn't create panic. So he knows what is happening. He's observed the treatment. He knows how to detect the problems so that he won't panic. And the nurse also, he can coordinate with them. Maybe suddenly something happens, he can actually help the nurse in a way, you know. And escalation process also. Suppose somebody has an acute situation at home, unfortunately, the nurse is attending to the emergency situation, this person can go and actually call the doctor or escalate the process or explain to the doctor, there is this problem and this has happened, what to do next, because he has seen the patient in the ICU. And develop a rapport with the doctor and the nurse. So he has a good rapport, it becomes easier.
Working together, for the betterment of the patient.
I have observed this very clearly, Mr. Mathur. The family gives him, the family involvement is good. I've seen a lot of patients getting better because of that. The family should not lose patience. You know, the patience is the most important thing, and if you are patient enough and supportive, you can actually pull out a lot of patients and you can make them better.
And the role of the family, if it is broadly defined, then you know they can that combination of the medical practitioners, the nurses, the doctors who are overseeing, plus a member or a couple of members of the family who are supporting, the two forces put together can make at times a dramatic difference in the well-being of the patient and recovery of the patient. You know?
Indeed.
Absolutely. So I've got a question now, personal for you. You know, you working in a very high pressure environment, in a pressure cooker environment. It has emergencies all the time. You know, and you're dealing with patients, and you have to provide the intervention, but at the same time you have to keep your cool, you have to keep your nerves, you got to follow the protocols, etc., etc., etc. So tell me, you as a professional, how do you view this whole thing and how do you manage it? Still smiling in the evening today.
So the one thing is the teamwork. It's not one person effort. That's why the critical care team is always, it's called critical team. It's not one person job. You know. So you handle a situation, very stressful situation, and you handle it as a team. You know. So you will be pressurized at that certain point of time, but there will be another colleague of you who can take off your pressure, and that's how we share our pressures. That's how we are able to handle this unit. And we have been trained in such a way that we have to handle both the ways. Otherwise, we'll not be able to manage the stress. So it is a very pressurized, intensive care situation. But I think with practice and with time, we learn the trick of the trade.
Absolutely, and I think you've touched upon a very, very valid point where you are looking at the whole sort of environment of critical care being in a hospital setting and also now being available in a home setting, right? Which has other benefits apart from the financial benefit. It also has the emotional benefit and, you know, environment different, lower infections, all of that. So I think in terms of capacity, you know, we can look at capacity within the hospital and capacity that's outside the hospital. And the two put together can really, you know, actually beef up a lot that has been lacking. And especially during COVID, we saw a lot of lacunae in that. But I think if the two put together can move to a concerted plan, then I think this whole critical care can be handled much better. And especially in smaller towns, right? We're in metropolitan locations, yes, very good. But if you go to smaller towns, we need to have it implemented there. Because again, you must have found that by the time some of the patients who actually come into maybe a tertiary hospital or wherever in a big city, their condition has actually deteriorated. And there are times you must have seen patients where, you really are fighting a rearguard action.
Right.
What's your thought on that?
You know, we have a term called time is brain, time is heart, time is everything. Time is very important. You know? So suppose somebody has an acute problem when he's at home or at work. The initial resuscitation is very, very important. So if you do it in the right way, when he comes to us, we can take it further and the recovery is faster. If it is not done in the right way, if you miss the boat there, then whatever we do it here is a waste. It's futile, you know. So that's where the picture of this qualified critical care unit comes into picture. So that's where you, the professionals who are there at that smaller town, they can handle it better. and the same continuity goes on, and we can treat them in a much better way.
That's excellent information, Dr. Himaaldev, that you've shared about what goes on inside an ICU, because it's like a black box, a mystery box, which is sitting out there, especially from a family's perspective, friends' perspective, all of that. So great. Any final thoughts you would like to leave with the general public about ICUs, critical care, and how to deal with situations like these?
I think we should debunk the mystery of, or the myth, that ICU is the end game. ICU is not the end game. This is where your family get better, your loved ones get better, because they are under the care of the highly professional, skilled people with a very high-end supportive techniques. And somebody who goes on ventilator is not the end thing. So there are a lot of patients who recovered once they go to the ICU and they come back. So when the need is required, it has to be done at the right time, at the right place. So that is very important. And also the post-ICU care is also very important, because that's where they are very fragile, and that is the golden time which has to be picked up quite earlier, and it has to continue. Whatever the care they have got, the same has to continue until they get better. So that's my final message. And thank you, Mr. Mathur sir, for having this wonderful session. And I'm sure it has reached many people who really require this kind of information.
Absolutely, and thank you very much for sparing the time and being so candid about all that you mentioned here. So until we have the next episode on some other area of speciality, we would look forward to welcoming you there for yet another episode on Awareness Program. Thank you for now.